Okay. So let's see what we can get through today. We could lecture for about half an hour and then spend about 20 minutes on review. Is everybody cool with that?
Yes.
Okay.
Absolutely.
No.
We need some more.
Okay, the only way that will work is if you guys tell me when half an hour is up, because you know how well I keep track of time. So,
got it.
all right, time me. Okay.
I feel like everybody's.
So, let's do a little bit of overview of the head and neck. So remember at the beginning of the chapter, we have this overview, and this overview is some of the highlights, like the most important things you can learn out of this chapter. So make sure you really get these topics down well. Thinking of that and thinking forward towards the end of the semester and studying for the final, these lectures, this first lecture of every section is going to be key. So make sure you focus on those. Don't ignore the rest of it, but these are going to be some of the big concepts that I really want you to take out of the class.
Will it be the same amount of questions and whatnot? Or?
Yeah, it'll be a 50-point question, 50 questions, and just over everything. But definitely these overview topics are going to be what are most important. Okay? So first of all, some just general orientation. So we've got several different cavities of the head. And your textbook has these really funky diagrams here that make me giggle every time I look at them. Because it looks like somebody's attempt to draw a robot or something. I don't know. Anyways, it's trying to show the spatial orientation of different cavities that actually intermesh with each other. So we have the cranial cavity, also known as the cranial vault. Okay. Embedded kind of in the edges of that and close to it are the cavities for the ears, so the portions of the middle and inner ears. Also extending into that would be the orbital cavities. And then below that we have the nasal cavities, and then finally the oral cavity. So we're going to hit up each one of these sections. And since your book likes to use this interesting little diagram, it's good to kind of get used to looking at them because they do them a lot. So hopefully we can use them to our benefit. Okay? A couple of quick areas of transition that you really need to be aware of. Okay, I said this properly last night, if I can get it today. Pterygopalatine fossa here. And it's a hole that's just directly behind the nasal cavities. And it's one of the main transition structures is the maxillary nerve. So this is part of the excuse me, fifth cranial nerve splits off, so that'd be the trigeminal nerve, and splits off into 3 different branches, and the maxillary nerve comes forward to innervate part of the face. Then we have the infratemporal fossa, so just below the temporal zone. And that noise is really annoying, whatever it is. And the mandibular nerve comes down through that to innervate the lower part of the face, the mandibular region. Okay, so these are 2 important fossa that we need to be aware of. There are many fossa and foramina in the head, but these are 2 that you really need to focus in on and know well. Okay. All right, so then some boundary definitions. So on the head, we have 2 major structures. We have the face, and the face goes from the bottom of the mandible here, kind of up to the mastoid process, and then kind of tucks. The superior edge of it is right at the superior edge of the orbital cavity, so kind of like that. So that would be the face. The scalp extends from the top of the orbital cavities around the top of the head to the external occipital protuberance, and that superior nuchal line right back there. And then below that, we transition into the neck. So down below here is the neck. Okay. So kind of the transition areas here-ish. All right, so we can see that transition area. So with the mastoid process, that little bump behind and below the ear, that superior nuchal line and the bottom of the mandible all create the superior border of the neck. So here we go, the superior border. The inferior border is the superior edge of the clavicle, the top of the manubrium of the sternum, and the top of the acromion. And then we kind of draw an imaginary line out from the acromion to the spinous process of vertebral level C7. And so this is the spinous process. Okay. That's the lower inferior border of the neck. Mm-hmm.
So your black line along the neck is your spinous process area, or where is your spinous process going?
So the
Are you
spinous
just
process,
identifying the one spinous process there?
this spinous process right there.
Okay.
And so it's an imaginary line between the top of the acromion and that spinous process. That forms that posterior border, inferior border. Okay? So then everything below that would be either shoulder or thorax, obviously. Okay. All right, so then in the neck we also have some major compartments. So we'll start with the visceral compartment. So the visceral compartment, and these are all fascia bound. Visceral compartment contains the esophagus, the trachea, and the related glands. So like the thyroid gland. Excuse me. Okay. And we have the vascular compartment, which very self-explanatory, contains the major vessels moving through the neck. So jugular veins, carotid arteries, etc. And then we have a vertebral compartment, and this contains the vertebral column and then all of those associated muscles. Right. And then finally, we have the musculofascial collar, which is kind of a compartment of its own, but kind of a compartment around a compartment. So basically, this contains the superficial muscles that surround the whole neck, so that it's continuous around the whole neck there. Kind of surrounds all the rest of the compartments. Okay, those clear? Okay. So then, here's our awesome diagram again. Think about the two major regions of the visceral compartment is going to be the pharynx and the larynx. Remember, the pharynx has three parts: the nasopharynx, directly behind the nasal cavities, the oropharynx, directly behind the oral cavity, and then the laryngopharynx, which is just behind the larynx. And then it continues on into the esophagus. And then the larynx also continues on as in the trachea. So just to remember that we have epiglottis that covers the laryngeal inlet, and it's this kind of leaf-shaped flap of tissue that then is pulled down to cover that inlet anytime we're swallowing. Okay. Also, we have the thyroid cartilage, which is that cartilage that surrounds the larynx and protects those laryngeal structures. That's enough on that one. Okay, general characteristics of the skull bones. So there's a lot of them. One thing that's characteristic is they're a flat bone, so it's 2 layers of solid bone sandwiching a thin layer of spongy bone. Okay. So there's the solid layer, and then there's the spongy bone in between. Many of them are paired. So there's one on either side of the head. Even like the maxilla has a split in the middle, so it's actually a paired bone that's been fused together. What else was I going to say about it? Oh, yes. And so then the joints between them are going to be solid joints. And what is the name of those joints? Sutures, yep. And those sutures are held together by connective tissues called the sutural ligaments. Okay. So here are some of the major sutures you need to know. The coronal suture between the frontal bone and the parietal bones. In the coronal, one of the coronal planes. The sagittal suture, which goes between the 2 parietal bones. So here's our 2 parietal bones. And then the lambdoid suture, which is between the parietal bones and the occipital bone. So those are the major sutures that you need to know well. So this would be the adult or older child. This would be an infant. And in the infant, these sutures haven't completely closed. The bones haven't completely ossified. So we have areas of soft tissue between some of the bones of the scalp, and these are called the fontanelles. We have 2, the posterior fontanelle and the anterior fontanelle. And any guesses why we have that? Anything?
Get through the vaginal canal.
So it allows deformation of the skull as the child moves through the vaginal canal. What other potential? Growth, right. So during the first few years of life, the brain goes through an explosive expansion and growth. It really increases in size. This is when the brain is forming huge numbers of new connections as the infant is taking in sensory information and producing motor activity much more than they would in the womb. So huge numbers of neurons being born and new circuits being formed. I mean, it's just crazy what's going on in that time frame. And so the brain needs to be able to expand. Excuse me. These do start to ossify and close off so that they become the solid joints. The posterior fontanelle, this occurs at about 1 to 2 months. And the anterior fontanelle is about 7 to 19 months. Become ossified. Typically, in the infant that's healthy and happy and all of that, there's just a slight depression in the surface of the head over these fontanelles. They can bulge out, however, if there's an increase in intracranial pressure. And different things that could increase intracranial pressure can be simply them being really mad and screaming their lungs out. That can cause a bulge. Or it can be something as serious as meningitis or hydrocephaly or something like that, to actually other ways of increasing intracranial pressure. Any questions? We good? Okay. So this is a blast from the past. So remember our cervical vertebrae. In general, here's just a general one. So remember our spinous process, these are often bifid. So it means that they split into 2 And then we have the foramen transversarium, and that's a hole in the transverse process. Anybody remember what passes through there? Yeah, vertebral. I can't spell today, my gosh. And the vertebral arteries are 2 of the 4 main arteries that supply blood to the head and the brain. Okay. So remember our atlas bone. This is C1. And remember we have broad articulating facets for the occipital condyles of the skull and the articular facet for the dens. And then on the axis bone, we have that dens, that protrusion up, which actually is embryologically the body of the atlas. And this joint, so the articulation between the dens and that articular facet there is what allows for rotation of the atlas on the axis. So it allows for rotation of the head. And so just a reminder of how they fit together here. And remember that the transverse ligament of the atlas is what holds the dens into the articular facet. And so you see here the occipital condyle of the skull articulating with that broad facet on the atlas. Excuse me. Okay, so those are just a few things that are important to remember with the cervical vertebrae. Then we have the hyoid bone, and what's special about the hyoid bone?
It's not with another bone. Like
Right. Yeah, so it does not articulate with any other bone, so it's kind of just floating in a mass of soft tissue, right? It's a really important muscle attachment site. And it also, a fact that it's not articulating with the bone allows it to have great degree of motion, so it moves a lot during swallowing, during speaking, allows some flexibility while still maintaining a rigid, strong attachment point for the muscles of the neck. Okay. And just for location, it's just above the larynx, so we have the larynx here with its excuse me. The name is that cartilage again. Geez, thyroid cartilage. Wow. And so then this little protuberance here at the top edge of the thyroid cartilage is called the laryngeal prominence. And that can be a way of finding. So you find the laryngeal prominence, the hyoid bone is going to be just above that. Okay. All right. So then another key concept would be the soft palate. And it's a cartilaginous flap that comes down over the opening between the oral cavity and the oral pharynx. So we can see it diagrammed here as this little swinging door thing. It's got 4 different pairs of muscles attached to it. So here we've got muscles attached to allow it to either be elevated or depressed during either swallowing or breathing. And these muscles are innervated by predominantly the vagus nerve. And so you guys, in HCPCS, have you guys gone over testing the muscles there?
Just today.
Yeah, so just today. So what do? You say ah. What do you look for? I'm really curious. What do you look for?
Symmetrical elevation.
Oh, so if like one side's elevated and the other's not, then that means like one of the vagus nerves is damaged. That's kind of cool. I kind of want to see that. Very cool. Okay. I love this class. I learned so much. All right. So then, structures that enter the neck from other regions, so ones that briefly pass through it, remember, are our subclavian artery and vein and our brachial plexus. And they're just going from the thoracic out inlet to the axillary inlet. Just brief point here. Then obviously we have our esophagus and trachea moving up into the neck. So just kind of reminding you relationship between these other structures or other regions. So then, like we had in the thorax and the abdomen, we have levels that are really important. So one of the levels is the level at C3, C4. And there's several different things that happen at this level. So it's the top of the larynx. Kind of see it at the top of that thyroid cartilage there. It's also the location where we have the bifurcation between the common carotid artery and the external and internal carotid artery. So we see that bifurcation right there. And I don't know how far you guys are in phys, but have you gone through cardiovascular and respiratory stuff? Yeah. So then, what are some receptors that are really important? Baroreceptors and have you guys done kidney stuff yet? Okay. So we also have chemoreceptors that detect the osmolarity and remember the CO2 concentration, all of those types of things. So remember those are all right there. That's that carotid sinus right there. So we have baroreceptors and chemoreceptors. Very important. Okay. Our other level is the C5, C6 level. What do you say about that? To remember. Ah, yes. This is the bottom of the larynx, then. And it's also where the trachea and the esophagus proper start. So that's that transition between pharynx and esophagus and between larynx and trachea. Okay. All right, so then several structures in the neck that are going to be clinically relevant, especially for establishing surgical airways. So when somebody's got, some sort of obstruction in the upper airway, we need to establish an airway down further. We can do cricothyrotomies and tracheostomies. And for the cricothyrotomy, it's going to go through the cricothyroid ligament. Here we go. So, right there, between the thyroid cartilage and the cricoid cartilage. And they do that up there because it's high enough that we miss these inferior thyroid veins. So we're up above structures that could potentially be a problem if they're damaged. And this is typically an emergency procedure, so this is a location for emergency. Okay. The tracheostomy, on the other hand, is typically done in hospital. It's done open so that they can more carefully avoid delicate structures. Yeah.
Actually, it's percutaneously placed. Open is an old-fashioned way.
Oh, really? So now what do?
They make the outer incision, they insert a guide wire, and then they insert a series of dilators to dilate that. And they slide the trach tube over it and remove it.
So they don't actually do an
It's
incision
bedside,
anymore.
Percutaneous, yeah.
Wow. Okay,
So
that's
you
kind of
only-
cool.
It actually heals up a lot better when you pull the trach then, because you're not surgically cutting all of those muscles, you're just kind of making a little hole.
That's smart. I like
So-
that. So how big is the tube that they can use for the?
Depends on the size of the person. Generally, they place an 8 perc, which is a diameter of about 12 millimeters.
Okay.
So
Very interesting. And do they still place it down between the
still in the same location.
like the 2-3 cartilage
And
rings?
placing it there, actually, part of it, the reason for placing it there is so they don't impede the
Yeah.
Because anywhere else you're going to have trouble passing a food bolus.
Right, okay. Yeah, so then it would be down in this region there, but then they just kind of
Right.
tuck
You
between
think about
things.
If you put it down there, the angle of the trach is not going to be very efficient. I mean, it's going to
Ah.
pop out because it's too far down the instruction of pushing it out.
Oh,
So by placing it up higher, it's actually more secure.
interesting. Wow, that's really cool. So then it would be up closer to the thyroid gland or above it? So still below or above it?
It's still below.
Okay, so up here, so that would be for the tracheostomy there. That's really interesting. All these advances. Apparently your book needs to update itself. All right. All right, so then, remember we've got parasympathetic nerves coming up out from the some of the cranial nerves. And so what's interesting about these parasympathetic nerves that often send innervation to the face is they often actually leave their nerves, so these parasympathetic fibers leave their nerves and join the trigeminal nerve. So you can see here's the trigeminal nerve, cranial nerve 5, and it's sending branches out to different regions of the face. And then we have the parasympathetic cranial nerve, so the ocular motor nerve, the facial nerve, the vagus nerve, and the glossopharyngeal nerve, all sending some branches out to actually join with branches of the trigeminal nerve to come and follow it along to its target. So just remember, we have these 4 cranial nerves sending branches to join the different branches of the trigeminal nerve. The trigeminal nerve branches are designated V sub 1 through V sub 3, and those are the ophthalmic nerve, the mandibular nerve. Then they have V2 here, they didn't label it. This is the maxillary nerve. V2. Okay. All right.
Are we gonna review then?
Let me do this next slide real quick, and then let's switch to review. Yeah, because that's a nice breaking point for us. For the next 2 slides. There's so much to talk about. Okay, so cervical plexus, we got the lumbar plexus, we've got the brachial plexus, we have the cervical plexus. Again, it's an intertwining network of nerve fibers contributed to by spinal nerves C1 through C4. We're not going to know it like we know the brachial plexus, no big deal. But we do need to know that there are some branches coming off it, the ansa cervicalis. And these, it's kind of a funny little loop-shaped structure. And it sends innervation to what they call the strap muscles of the neck. And these are muscles that go around the larynx. Excuse me. And attached to the hyoid bone, and they're important for controlling the voice. We'll talk about them more later. And then let me just quickly go through dermatomes. So for the face, innervation is from the trigeminal nerve. All right. And you can see the 3 different branches of it. So the ophthalmic, innervating the scalp and orbits in the nose. Okay. The maxillary nerve kind of coming down the sides, part of the temples, and then the maxillary region and part of the nose, and then the mandibular nerve coming down to do both the posterior temporal area and the mandibles of the mandibular region. Okay, then we have C2 through C4 spinal nerves taking care of the rest of the innervation, and we have the posterior rami showing themselves again. So the back of the head and neck, so the posterior surface is innervated by those posterior rami, whereas the anterior parts are the anterior rami. So this is kind of where we break down the difference between the posterior rami and anterior rami. So before it was all just, and posterior rami were all intrinsic muscles of the back. Well, now we're getting to the head and neck. That kind of organization no longer works as well, so we have more generalized distribution of the innervation by posterior rami and anterior rami. Okay? So we'll stop there for lecture and do some review. Let me export this. Okay, so what are the parts of this that's most daunting to you?
The origins and insertions.
Origins and insertions? Yeah, okay.
How specific are you gonna be at? Like, do you want us to know, like, what's the, like, 1/3 of the whatever?
No, I want you to know the main structure that's the majority of that origin. So, you know, lateral epicondyle or whatever. Doesn't need to be the superior aspect of the lateral epicondyle and the, you know, a little bit above it, whatever. Doesn't need to be that specific. Mostly what I want you to get out of the origins and insertions is help with the functions. So that's where that is important. So if you know the origin and you know the insertion, the function's easy after that. So it's going to be related to function. So say okay, you got an avulsion fracture on the insertion of a muscle. Where's the fracture going to be? What's going to be the problem, kind of thing. Those kinds of things. It's not going to be a heavy weighted test on the origins insertions. I'm going to pick a few that are a little bit better known. I'm not going to go into the nitty gritty, tiny little detail ones. I don't feel that's going to be helpful to you guys or reflect your knowledge of the material very well. So it's going to be pretty low proportion of the questions will be the origin insertions. Most of them are going to be function innervation kind of questions. How does it work? What's going to happen when something goes wrong? Okay. Other questions?
Can we talk about innervation in the arm?
So, come on. Which part? All of it, everything, some of it? Let's see what we got here.
Well, we can go over brachial plexus, but then a lot like into the forearm and hand.
Okay. Yeah, the forearm and hand get a little crazy, don't they? So, brachial plexus, that one is in 3. Yep. Okay. So,
Was
yeah.
this one labeled wrong? Or purple goes with blue, right? The trunk is needs to be
Sorry? Did I get it backwards? Okay. Quite possible I do get things backwards. Okay, so this is probably easier to work with right now. So remember, we've got the roots that are C5 through T1. You don't need to know those specific, like which one's contributing to each root. Starting here is where I really want you to think about superior, middle, inferior. So it's just knowing the branching pattern. So musculocutaneous nerve what is it going to be receiving input from? So fibers from which trunks? Superior and middle. Divisions is just going to be the anterior division, lateral cord, kind of trace it that way. Okay. So then if we damage, say we damage the anterior division and the superior trunk, so this area right here, if we damage that area, what nerves are going to be impaired? Musculocutaneous and radial nerves. And median, yes, that too. Got that branch. Yeah, okay. Good. So that's kind of what I'm looking for there. Remember, you don't have to know these little guys here except for the axillary. It's the only one I want you to know off of there. Any other questions off of this that are, anything else that are, does that kind of help with it a little bit, or?
Yeah.
Okay. And so then this was just kind of figuring out how that works anatomically, so why we have the names, the different names for the trunks, divisions, and cords is their relation to the axillary artery. So probably, most likely what I would do is give you a labeled region and say, okay, what's that structure? Knowing what each of those structures is. Okay. And then remember the damage. So if we damage the upper portions, predominantly going to be which nerves? And median. And then we have Erb's Duchenne palsy, the results. And what's the sign for that? Waiter's tip. Yeah. Okay. So then if I really wanted to be mean, I could say, okay, what muscles might be affected there? That would be really mean. Yep, exactly. Anterior compartment of the arm, and that's going to cause what to the what's going to be the right? You can't flex the arm, and so for the waiter sign, it's a very straight arm. That's that definition of musculocutaneous damage. And then it's going to be pronated, so it's going to be the supinators that are also having some damage too, right? Because it's a pronated, right? And wrist flexors. Okay. All right, damage to the lower portion. Those are going to be which nerves? Radial and ulnar. And so the claw hand is going to be predominantly because of damage to the ulnar nerve. Right. All right. That helpful?
So just to review for the Erb's Duchenne palsy.
Erb's Duchenne palsy.
It's all the flexors for the arm. That's why it's straight like that.
Right. So remember, the posterior compartment is innervated by which nerve? Radial. So it's predominantly okay. And remember, in a normal limb, we've got tension in those muscles all the time. So it's a balanced tension between the anterior compartment and posterior compartments. And so when one compartment goes out, then the other one's going to take over and actually extend the joint back that way. Does that make sense? Okay, that's also why we have the claw hand thing, because there's, again, an imbalance of muscle tone between the flexors and the extensors. Okay. So, is that good for the brachial? Kind of give you guys some ideas there? Okay, so then we wanted to do forearm and hand. Okay, so forearm is going to be here-ish, I think. Do I have that? Huh?
Which lecture?
I'm trying to decide. It's 5, I think. And so then, I don't have a compartment picture, do I? That was silly of me. Okay. So anterior compartment. It's going to be mostly the median nerve, right? So That's the median nerve. The ulnar nerve is just going to hit up a few of those medial. So it'd be the flexor carpi ulnaris would be the ulnar nerve for that one. So then, let's see here. So if we have damage to the median nerve, what are all of the different motions that might be impeded in the forearm? Mm-hmm. Flexions of the digits. Mm-hmm. Mm-hmm. Yep. Good. What was I going to say? I forgot. Oh well. Whatever. It's to the point where I just get used to forgetting everything. Okay. So then, on the posterior compartment, then what's going to be the major nerve that innervates that region? Sorry? Radial. Yeah. And so then we have radial damage. We're going to have problems with. Yeah, wrist extension. So we're going to have wrist drop, right? Yeah. So. That's arterial supply, vascular fishes. Right. Right, and then then we have this one exception here with the superficial branch of the radial nerve that does kind of stay in the anterior compartment-ish, but it's entirely sensory, remember? So, entirely sensory. Okay, so the trick to all of this forearm muscle innervation is to know the rules, and then there's just a few exceptions. So just know those few exceptions, like the extensor carpi, or flexor carpi ulnaris be the exception to the anterior compartment being innervated by the median nerve. So those few exceptions to the rule. Okay, that help? Okay. What else? What else is? Okay, so then we want to do hand, right? So that's going to be the next lecture, right? Where is it? Here we go. So remember, we've got these funny little diagrams for the hand. So ulnar nerve is going to be the medial part of the hand. And remember, we have this funny little thing where half the nail bed of the fourth digit is the median nerve rather than the ulnar nerve. Why? It's always a good question, but. And then remember that this diagram doesn't show it very well, but we have the deep branch of the ulnar nerve kind of coming out and innervating some of these lumbricals and interosseous eye muscles. Okay. So then we have the median nerve, and compression of the median nerve can occur where? Carpal tunnel, right? And so then that would cause what kind of deficits? The median nerve. Yeah, so you'd have some lot of numbness, paresthesia, tingling, things like that, and then some difficulty moving these lateral 3.5 digits here. So we've got the sensory information covering this whole area, and then those muscles in this region here, the motor region there. Okay. And then remember, we've got the recurrent branch there, taking care of all of those thenar muscles. So what are the thenar muscles?
Abductor muscles, or pons pollicis,
Mm-hmm.
and the flexor pollicis brevis.
Dr. Paul's Brevis, yeah.
I have a question. So on the green part, it's
Mhm.
completely sensory. There's no motor innervation because all the muscles that move the fingers are more proximal, right?
Right, yeah, so there's no muscles in that region, it's all just connective tissue and fat and stuff. Yeah. Exactly. Any other questions? No? Okay, and so then finally our radial, remember it's entirely sensory, so we just have filling in the gaps of the sensory information here on the lateral portion of the hand, the dorsal part of the hand, and that's that superficial branch of the radial nerve. Okay, is that helpful? So a lot of these would be, okay, if you lose nerve function, what's going to be the problem? So think about what muscles are going to be in that area, whether they're going to cause flexion or extension of the structure, etc. Okay. What other questions?
Can you go over bunions again?
Okay, yeah, sure. Where was that? Oh my gosh, that's a long time ago. Okay. Okay, yeah, so bunions. So bunions itself is actually just an inflamed bursa. So it's just an inflammation of one of those sacs of synovial membrane that cover areas with high friction. Okay. The movement of the joints is actually called hallux valgus, right here.
But that's associated with bunions?
It's very commonly associated with bunions because that condition of hallux valgus is going to push that region of the foot out, and you're going to have increased friction between the foot and the footwear. Okay. So you can think of that metacarpal phalangeal joint moving medially, right? Because the big toe.
Right.
So we're moving medially. Okay. And so
Well, so then in the notes it says lateral displacement of the great toe with medial displacement of the metatarsal 1 and lateral displacement of the metatarsal phalangeal joint.
okay, so it should have been medial displacement
So
of the
that-
joint. Yeah, that is, I got myself backwards there. Doesn't even make sense with the other parts of what I wrote. Obviously, I was tired.
So medial displacement of the metatarsal? joint?
Right. Yeah, the metatarsophalangeal
Lateral
joint.
displacement of the interphalangeal joint?
Yeah, so of the phalanges. So the toe moves laterally, kind of moves out this way,
Yeah.
and then that
Just
the joint just
terminology
moves.
is kinda confusing.
It is confusing, keeping it straight and remembering that our toes are
I just mean,
big
you'd
toes.
ask a test on it, you'd say that the metatarsal phalangeal joint moves medially.
Yes, and the phalanges
toe
move
moves
laterally. Yeah.
So the picture looks like the toe is moving medially.
Yeah.
Sorry.
Does the picture just look like the toe is moving medially, but it's
No,
supposed
it's
to
just
move?
lateral.
But technically it is laterally erased.
Right. So the toe itself is actually going to go from being straight to the axis is actually twisted compared to the location of the metacarpal. So the phalange is going to actually shift over.
It just looks like it should.
Yeah, it's lateral to the body. Because remember, our toe, big toe is the most medial toe, and so any movement towards the rest of the foot is going to be lateral.
And it's moving medially.
That help? Yeah. Yeah, so it's medial displacement of the metacarpal phalangeal joint. Got that one back. Again. Okay. All right. Any other questions? Last minute.
So you just don't have that axis that's scratched by like the actual.
Okay.
Because the picture, sorry, it looks like
It does.
Yep.